Welcome, and thank you for joining us today. Thank you for your interest in our report. My name is Rhea Farberman. I'm the Director of Strategic Communications and Policy Research at Trust for America's Health, also known as TFAH, TFHA, TFAH. TFAH is a nonprofit, nonpartisan policy organization. We work in the area of public health doing advocacy, research, and policy work. We work to advance those policies that will support optimal health in every community. Before we get started, a few housekeeping notes. We'll hear from two presenters today, and then we'll reserve about 30 minutes for your questions. If you've submitted a question ahead of time, thank you. We'll get to those. We also invite you to submit questions during the session using the Q&A function. And we'll get to as many questions as we can during the session. If we're unable to get to your question, someone will follow up with you this afternoon. Finally, today's session will be recorded, and the recording will be available upon request. It's now my pleasure to introduce our first panelist. Dr. J. Nadine Gracia is the President and CEO of Trust for America's Health. Before joining TFAH, she served in the Obama administration as the Deputy Assistant Secretary for Minority Health and the Director of the Office of Minority Health at HHS. Dr. Gracia.
Thank you, Rhea, and greetings. Thank you all for your interest in our report. This is the 22nd edition of TFAH's Ready or Not, Protecting the Public's Health from Diseases, Disasters, and Bioterrorism report. The report's findings and recommendations are just as important to our nation's health and economic security as they were when TFAH released the first report of the series in 2003. The report comes at a critical time. The nation is in the midst of a surging measles outbreak. Bird flu is a threat to health and the economy. And weather-related disasters are occurring more often and with greater intensity. And federal cuts to public health funding and workforce put an already under-resourced public health system at greater risk. Next slide, please. Let me open with the report's most fundamental conclusions. A strong public health system safeguards health and the nation's economic and national security. As a nation, we are less prepared for public health emergencies than we need to be. State and local health departments rely heavily on federal funding and technical expertise, and the proposals in Congress and the administration to significantly scale back public health spending and workforce will have devastating impacts on state and local public health programs, including their readiness infrastructure. Public health infrastructure, particularly in the areas of data systems and disease detection, actually significantly improved as a result of the infusion of funding in response to the COVID-19 pandemic. But that funding was one-time money, which has now been spent or in some cases rescinded. That progress is now at risk as many state and local health departments are facing funding cliffs. CDC's comprehensive focus on health, including infectious and chronic disease, plays an important role in emergency preparedness and should be preserved. And finally, social and economic disparities put some populations at greater risk during emergencies, including people who live in rural areas, older adults, individuals and households with lower incomes, and people living in areas prone to floods, wildfires, and other extreme weather events. Next slide, please. Let me now move into some more specifics with the background and purpose of the report. The report examines the nation's preparedness to respond to public health emergencies by measuring states' performance on 10 key indicators, including healthcare system readiness, public health laboratory surge capacity, state public health funding, employee access to paid time off, flu vaccination rates, and water system safety. Next slide, please. The report's findings show that there is significant room for improvement in the country's emergency preparedness. Our analysis placed 21 states and the District of Columbia in the high performance tier, 16 states in the middle performance tier, and 13 states in the low performance tier. it's important to note that all states, regardless of their tier placement in the report, can improve their emergency readiness. Next slide, please. Overall, the report found areas of strong performance as well as areas and opportunities for improvement. I'll start with the areas of strong performance. First is around expanding healthcare capacity. More states have adopted the Nurse Licensure Compact that allows nurses to work in any member state with a single multi-state license. The compact allows healthcare facilities to surge nursing staff during an emergency. As of January 2025, 41 states belong to the Nurse Licensure Compact, which is an increase from the previous year. Secondly, public health laboratory surge capacity. 47 states and the District of Columbia have a written plan to surge public health laboratory testing capacity during an emergency. Such a plan to quickly scale up testing is critical to ensuring timely infection diagnosis and disease tracking during a health crisis. And thirdly, water safety. In most states, at least 95% of residents served by community water systems had a system that met all health-based health standards. A system's ability to provide safe water, both routinely and during emergencies, is foundational to protecting the public's health. Next slide, please. Now, in terms of the areas that need improvement, those include avoidable mortality. And this is a new indicator added to the report this year. This indicator measures deaths before the age of 75, overall and by race or ethnicity. These are deaths that can be prevented by strong public health measures and programs, and ones that could be averted due to available healthcare intervention. TFAH's analysis shows that deaths from avoidable mortality varies widely across the country, reflecting differences in healthcare access, public health infrastructure, and underlying social and economic factors. Lower rates of avoidable mortality within a state typically reflect better population-level health and fewer health disparities, both of which are critical to reducing the impact of health emergencies. Secondly, the issue of state public health funding. 14 states reduced public health funding in fiscal year 2024, which is 3 more states than the 11 that reduced funding in fiscal year 2023. State investment in public health will be particularly important as Congress weighs budget cuts to federal public health spending. Thirdly, limited access to paid time off. On average, only about half of workers in each state used some form of paid time off during a given month over the past 5 years. Employers who provide employees with paid sick leave are not only helping to control the spread of infections within their community, they're also supporting their business stability and helping to safeguard the local economy. And fourth, low flu vaccination rates. Too few people are vaccinated against seasonal flu. During the 2023 to 2024 flu season, only 47% of the population ages 6 months and older were vaccinated against the flu. And that's down from the previous year and well short of the 70% goal established by Healthy People 2030. Next slide, please. Now, importantly, the report also provides recommendations for policy action. The report provides benchmarks and recommendations for federal, state, and local policymakers and health officials to measure and improve their emergency readiness. 2 issues that are important to understand as we talk about these policy actions are that 1, every state can improve its performance, including states that are in the high performance tier. And secondly, multiple sectors have a role to play in improving the nation's emergency readiness, including healthcare systems, the business community, and individual families. The report includes dozens of recommended policy actions within 7 priority areas. First, stable, sustained, flexible funding. Congress and states should increase predictable, long-term investments in public health infrastructure and workforce. TFAH supports providing annual appropriations for CDC, of at least $11.5 billion annually starting in fiscal year 2026. It's important to know that 80% of CDC's domestic budget goes to states and local communities and other entities to support public health infrastructure and health promoting programs at the local level. Secondly is around effective leadership. Evidence-based decision-making and coordination are critical to protecting health during public health emergencies. Congress should reauthorize the Pandemic and All Hazards Preparedness Act, also known as PAPA, to improve the nation's readiness for a range of health threats. Thirdly, on outbreak prevention, we need to enhance immunization programs and address antimicrobial resistance. Congress and the administration should preserve and grow CDC's National Immunization Program, which ensures access to effective immunizations on a routine basis and in response to outbreaks. Vaccination is the best tool in public health's toolbox to prevent the further spread of the current measles outbreak, for example. Fourth, as it relates to communities,
Washington State, wildfire, smokes, COVID-19, other infectious diseases, and most recently, avian influenza. Globally, I've deployed after major earthquakes, including responses in both Kashmir and Haiti. Nationally, I've served on the board of ASTHO, which represents state and territorial health agencies, as well as I've served as the president of NACCHO, which represents 3,000 local health departments across the US. And why I bring all this to the table is that these experiences have taught me that while geopolitical systems may differ, the underlying themes remain the same. And the most important lesson that Dr. Gracia mentioned, and I will reemphasize, is that we must be ready because another emergency is always just lurking around the corner. And in response, we have to be thinking about what I call communication as well as communication. And so what this blueprint is not just a report, it's more than a policy document, it's a call to action. Its 7 priority areas reflect what public health professionals and health professionals in general know. Readiness is not episodic, it must be continuous. And I'm not going to go through all of the 7 priority areas that Dr. Gracia so eloquently mentioned, but I'm going to touch on a few of them. First, we have to invest before the crisis hits. Crisis funding absolutely helps, but it cannot be our only strategy. We need stable, flexible, and sufficient funding for public health infrastructure before the next emergency hits. Both in Texas and Washington, we push for that sustained investment and building. One of the most important of what I call these 3 C's is the dependence on sustained investment. Next, we have to have leadership that really are the key to this life-saving infrastructure. This is not a tax the lives of Americans every single day. During the pandemic, we know the cost of fragmented people. Public health leaders need coordination across all act decisively. And this gets to that second C of coordination and collaboration. Without it, our systems are only as strong as their weakest link. Whether and how resilience begins at the community level happen in local communities. And that's why the importance of the third is a critical part of and must be equity informed, and it must be supported at all levels of government. Healthcare and public health must also work together. While I'm not proud practicing clinically as actively now as I did over the last 2 decades in emergency care environments, for example, in the VA hospital system, caring for Washington State health care were unsupported. The whole system environment and the climate. We know that wildfires, extreme, that these incidents happen on an almost regular basis. The environment is no doubt already impacting our health, and it's escalating. Climate readiness must be built into the future. Unfortunately, it's about the now. Domestic health. What happens across and what happens domestically, we've seen this with pandemics. Domestic health security must be local, must be domestic, but it must be mindful of the global context. So in closing, let me say the Ready or Not report is a reminder of what's at stake. If we get this right, we save lives, we protect communities, and we strengthen trust. We must all commit to communication, collaboration, coordination, and capacity building, and invest in both healthcare and public health readiness alike. Because readiness is not just about what we do in a crisis, it's about what we build every single day. Thank you, and I'll turn it back.
Thank you, Dr. Shah. We're now going to move to our Q&A session, but before we do, let me introduce two additional members of the panel. We have Matt McCullough, who is a senior health policy researcher and analyst at TFAH. He's one of the co-authors of the report. And Dora Lieberman. Dora is TFAH's Director of Government Relations. She and her team work to bring policy solutions on public health issues to Congress and the federal agencies. She's also a lead author of the report. If you'd like to submit a question, we invite you to do so now. Use the Q&A format. Please include, obviously, the question, your name, your outlet, and if you'd like the question directed to any particular member of the panel, be happy to do that. We'll probably have multiple members of the panel responding to questions as well. I will begin by sharing a question that was submitted earlier, and that is a question about the trends that the report uncovered and what the data says about a community's social and economic status and disparities, and how those disparities impact emergency readiness. Dr. Gracia, do you want to get us started?
Ria, I'll be happy to start us. This is an important issue. You know, time and again, when we look at emergencies and disasters, we see that there's communities and populations and groups that often are disproportionately impacted in those emergencies and disasters. Not only are they disproportionately impacted in terms of the disaster or health emergency itself, but that may have a more difficult time in the recovery from such an emergency. You know, what is critically important when we speak about emergency preparedness and disaster response is that we have healthy, thriving, and resilient communities. That is critical to disaster preparedness. That means having a community that is not only healthy, but that also we address the community conditions, social and economic conditions that promote health and well-being. Factors like housing, transportation, food security, access to healthcare, and many other factors. We see, for example, that people who live in rural areas, older adults, households and individuals who have low incomes, and other populations and communities often face and are often disproportionately impacted by emergencies and disasters. So critically important in emergency preparedness is to address those social and economic conditions such that communities are better prepared, because a healthy, resilient, and thriving community will be both better prepared for an emergency and also better able to recover from those emergencies.
Thank you, Dr. Gracia. Dr. Shaw, you may have an example from your work in Texas or Washington of a community that was at a disadvantage and wasn't able to be as resilient as other parts of the community and recover as quickly as other parts of the community during an emergency.
Yeah, thank you, Ria. I would say that there are myriad examples of this, and I can go back as far back to Tropical Storm Allison in 2003, or the Hurricane Katrina response with the 27,000 evacuees that were at the Astrodome in Houston, where we were spending an inordinate amount of time for several weeks with the largest sheltering operation in the history of the United States to date, to really make sure that we were providing for the socioeconomic needs of individuals. And what we found is that as we were trying to take care of their health needs, the social factors, the impact of their entire life was having an impact on their health. And you cannot have health without safety. You also cannot have health without addressing those social factors. So you fast forward, not just what happened in those storms, but also in other emergencies, including here in Washington, as we responded to a whole host of additional urgencies and challenges, even as what we may not always think about as an emergency in the same way, but when we had infant formula and supply chain disruptions just a couple of years back, we had a similar concern where individuals who did not have the resources and have the ability to be able to provide for their own families the very infant formula that was necessary, those were then needing to get support from all of us in being able to bring the supplies to them. So I think it's a significant concern that all of us have, that it's not just about an emergency playing out and the impact on health, but it's all the other social factors that surround both the individual, but also impact the community at large, that have an incredible impact on whether that community and that individual does better or not better as they come out of that emergency.
Thank you, Dr. Shaw. We now have a question from the Dallas Morning News. They've been covering the measles outbreak in the state. They're wondering about the state's level of preparedness and its impact on their ability to control the outbreak, and whether states that are highly prepared in terms of emergency response will be able to more quickly contain something like a measles outbreak.
Dr.
Dr. Shaw, do you want to?
Yeah, is it
Sure,
okay
please jump in.
As having spent 2+ decades in Texas, I have a lot of history with the public health system and the healthcare delivery system in Texas. And I would say two things. One is that Texas does have resources and has incredible leadership at the public health agency led by Dr. Schuford, the health commissioner for the Texas Department of State Health Services. I have an incredible amount of confidence and trust in her abilities. That said, we also have to recognize that we have a growing national phenomenon happening, which is that people are seeing very much the concern around infectious diseases that could be alleviated or prevented by getting vaccinations. People are not getting, in this case, their children vaccinated. That is a significant concern for all of us in public health. These are diseases that we should not be seeing in the same ways that we're seeing now, or in the amount that we're seeing now. And unfortunately, we are seeing those because there are concerns that people are unfortunately thinking through in their minds about why they should not get their children vaccinated. And that is a problem. That is something that must be addressed. And we have to and can only do that by engaging and building the confidence back in those very measles vaccines, But it can't stop with just vaccination. It's about investment. We have to have the investment in the very systems that create the opportunities for all of us to be healthy. And that's why this report that TFAH again has issued is really about, are we ready? Yes, we are ready, but it's a double-edged sword. We are ready, but we are not ready enough. We have to do more in order to continue to remind ourselves of the importance of being ready for the emergency that's right around the corner. And whether it's measles, whether it's a hurricane, or whether it's some other emergency, we have to be ready, but we can only do that if we proactively invest in those systems.
If
Thank
I
you.
may add
Please.
to the excellent points that Dr. Shaw shared, in particular those final points, really because that's an important understanding of what the Ready or Not report and these indicators are conveying, is that when we speak about emergency preparedness, it may be one emergency, it could be multiple emergencies happening at the same time. And every day there's the importance of addressing the foundation of public health, the core capabilities that we need to have in terms of the workforce, the systems, and the services that are provided to be able to rapidly respond to the diverse types of health threats that exist, whether they are infectious disease outbreaks like measles, or whether they are natural disasters, environmental disasters, bioterrorism, and the like. And what these indicators are really providing is an opportunity and understanding and the ability for policymakers at all levels, federal, state, and local, for health officials, for other sector leaders to take action, to understand that having these core capabilities and this capacity in emergency preparedness when it comes to the ability to surge your healthcare workforce, having public health laboratory surge capacity so that you can do the testing that is needed to be able to identify and contain these outbreaks, to assuring that workers have access to paid time off so that they don't have to make the difficult decision of whether to go to work and potentially spread an infection, and businesses that also can be supportive of their employees to be able to stay home and really support their business needs, but also be able to protect the local economy. When you think about this holistically, that's what emergency preparedness is. It's being prepared for the face of any type of disaster and emergency and having that core capacity. And this gives states and localities and our nation and our national and federal policymakers really important action steps that they can take to shore up our nation's public health emergency preparedness and public health system overall.
Any other comments on that question? Okay, we have a question from Axios. It's about the preparedness tiers that the report includes. For states in the high performance category, what should the consumers, health consumers, state residents know about their state's readiness? And the same is true, same question for states in the middle tier and the low tier. What's the messaging? What should state residents know about their level of state preparedness? And are there any states that are have unique qualifications, have a unique approach in terms of readiness that would be worth pointing out? Matt McCullough, can we go to you, please?
Sure. Thank you, Rhea. You know, as we design the indicators that we track and the way that we position states in the tiers, you know, I would start by saying every state has large numbers of highly qualified, highly dedicated public health officials, healthcare officials who are working every day to keep residents safe. And at the same time, every state we see has room for improvement. I would say, as you look across the tier placements, you know, what we tend to see is that states that are in the high tier in the indicators that we look at, which are designed to capture a whole host of capabilities and think of the full range of potential threats and hazards that a state could face. The states in the high tier tend to have taken perhaps additional actions, such as becoming accredited by highly regarded accreditation bodies, or perhaps joining the Nurse Licensure Compact, which is a way that states can have nurses, out-of-state nurses, come into the state to assist with healthcare surge operations, perhaps have taken additional actions relative to others to make sure that their preparedness efforts are shored up and that their capabilities are strong. Likewise, states that are in the middle tier or lower tier, as you look across the indicators, will typically have more room for improvement, that relatively speaking, their level of preparedness likely has additional areas to focus on, whether it's flu vaccination rates or paid time off and access to paid time off, or whether or not a state has a written plan to ensure that its public health laboratory can surge in the event of an emergency. What we see is that those states that are in the low tier or the middle tier really have additional room for improvement. And what we're trying to do is try to identify those areas that might be worthwhile to really focus on in the coming years with greater levels of investment and greater levels of attention.
Thank you, Matt. Anyone else commenting on this question about states' performance within the tiers?
I guess, Rhea, the only thing I would add to what Matt said is that, and then we have to remember that that state system is part of a larger ecosystem of federal, state, local, community, and it all works together. When the community has the emergency, the local health agency is usually the first one to respond and is the one that is going to be on the ground, being able to do all the different things that are required to safeguard their community. And the state then must have the resources to be able to support what's happening in that local health agency and beyond. That absolutely supports the people on the ground in the community. And the federal resources are so critical to support what's happening at that state and local level. And if we don't have that state and local level strong, then what you have is the challenge that Matt just spoke about, is that not just the investments, but the indicators start to show that there are some rooms for improvement. And we have to do our best to shore that up before the emergency is at hand. Unfortunately, there are a lot of emergencies already upon us, and that's the challenge that we have today.
Long segue to our next question, which is from the Post and Courier in Charleston, South Carolina. The question is about avian flu. And if avian flu, bird flu, was to become transmissible between people, would some states fare better than others? And what's most critical about being prepared for the potential for human-to-human transmission around avian flu? Dr. Gracia, do you want to begin?
Thanks, Rhea. And as you noted, Dr. Shaw really highlighted the importance of this response system, that it's not a local community or a state operating in isolation. You know, while the local health department and local agencies are first to respond, it is indeed operating in a broader system. And that is a broader system as it relates to avian flu, as it relates to other infectious disease outbreaks, other disasters. It is important that disaster and public health emergency response operates where there's coordination between community, state, and the federal government. We've talked about, importantly, how the federal government is such a critical source of funding for states and localities. Again, I'm going to repeat that 80% of CDC's domestic budget goes to states and localities and other entities to help support their public health infrastructure, the programs and systems that they provide. That's laboratories, that's workforce, that's the data systems, that's public health programs to help promote health and well-being in communities all across the country. Those federal agencies are also providing, importantly, technical assistance, expertise. You have subject matter experts who know how to respond to and address a whole host of these types of infectious disease outbreaks that can provide the technical assistance, both from the agency as well as supporting on-the-ground assistance to these local and state health departments and other agencies. There's also a coordination role that the federal agencies are playing, because as we've talked about earlier, these types of emergencies, they don't respect geographic boundaries and state borders. The federal government plays a critical role to provide coordination across multiple jurisdictions. That's what we see, for example, with a measles outbreak. That's what we see with a weather-related disaster like a Hurricane Helene. That is an important role and function. And having served in federal government at HHS, I've been a part of and have witnessed the importance of that federal, state, and local integration as it relates to emergency preparedness and response. In our report, there is a special feature specifically around bird flu, H5N1, recognizing that we need to really have that type of an integrated system to be able to address the bird flu threat. We also even include an interview from one of the state health officials in Michigan who talks about, for example, the importance of testing, having access to testing and having robust testing systems so that you can identify and contain outbreaks. The importance of multi-sectors working together. When we talk about bird flu, it's a clear example of the need for One Health approach with regards to emergency response. That's bringing human health, animal health, environmental health together and seeing, for example, public health agencies working in lockstep and hand in hand with departments of agriculture. It also means working with trusted community partners that can do outreach and education in addition to the local health departments, working with other organizations that also have outreach to the communities, the populations that are disproportionately impacted to assure that they're getting the information that they need, the protection and services that they need in response to and in preparedness for these types of emergencies. And then it's also critical, as Dr. Shaw and others are saying, that we don't wait for the emergency to happen, that we then build these systems and these partnerships. That trust and those relationships and partnerships and those systems need to be in place before an emergency happens so that we can have the most effective response in terms of preventing illness, saving lives, and minimizing the impact to our communities, our country, and globally.
Thank you. We now have a question from the second question from the Dallas Morning News. The question is about whether we have a sense for when the measles, how long the measles outbreak will last. I know that panelists will all agree that we don't. So let me massage the question a bit and ask the panel to speak to what is it most critical that public health do, and what is happening at the front lines right now in multiple states to control this outbreak. What's most important about controlling the outbreak and making sure that a measles outbreaks are a thing of the past? Dr. Gracia, do you want to begin?
So Dr. Shaw coming off me. Dr. Shaw, I know you've actually responded either one.
Well, I was going to say that, we don't know the answers to that because we don't know what pockets of communities their vaccination rates, where you have vaccination rates that are, at that well-regarded 97% or higher, then you have the increased chance of ending an outbreak sooner. The problem that we have is that we don't know where the pockets are, where the percentages of vaccination coverage for measles, especially in kids, is lower. And so what that does is it perpetuates. And so you can almost popcorn that you have a community or a school that has a higher vaccination rate. And so the majority of kids are protected. But now you go to a neighboring community or a school system where the children do not have as high vaccination rates, and now it spreads to those individuals. That's why it's so hard for us to predict how long this outbreak will last. But I do think the most important thing, which obviously I've just talked about, is the importance of vaccinations, Rhea. is the absolute importance of measles vaccine, MMR vaccine, the importance of getting vaccinated. School-age children must be vaccinated against measles. This is not a disease that we don't know how to prevent. We actually do. This has been a disease that we largely didn't see in the United States. Now we're seeing it on a regular basis. This should be a concern for all of us. And it's really interesting how we, in health, we work so hard over the years to come up with strategies or vaccines or other ways of protecting people. And then when you have those abilities and then people just don't take that vaccine, guess what happens? It renders it less effective or even useless. And we've got to do a better job of communicating. And so that's what is really important about what's happening, not just in Texas, but across the country, is that local health agencies, healthcare systems, partners in public health and healthcare delivery system, doctors, nurses, epidemiologists are working together hand in hand to fight measles. The problem is you can prevent it. And once you prevent it, it's a lot easier and it's a lot less expensive to do so. Now what we do is we bring all those resources in reactively to fight a measles outbreak. And again, when you reactively fight the measles outbreak or any other outbreak, you're behind the 8 ball. We've got to do a markedly better job of being proactive, building the capacity, creating the conditions in which people are knowing what steps are necessary in order for them to protect themselves and their families and their children. And we've got to do that in a way that people feel safe about asking questions, even concerns that they may have, and getting those answered and be able to then protect communities. And that's ultimately what this is all about. Dr. Gracia?
Yeah, Dr. Shaw, you said it very well, and again highlighting something that you said, where thinking about pockets of communities and when there may then have additional cases that arise. Again, that importance of then the ability to ensure we've got local working with state, working with the federal government and federal agencies, because the other unique role that the federal government is also playing here is with that impact that could be multi-jurisdictional is the data and helping to understand the trends, the tracking, and how to be able to anticipate what resources may be needed in other communities and to be able to provide guidance. You talked importantly, for example, with regards to our healthcare delivery system, providing guidance to healthcare providers, to clinics that are helping to provide access to services, immunizations, as our local health departments, what they are doing. This is a unique role that the federal government plays in partnership with states and localities, and these are long-standing partnerships. The complexity of these types of public health emergencies and disasters requires that type of partnership and integration at all levels, and it requires the resources, as you said. Prior to the emergency, it requires the resources during the emergency and sustaining those resources so that you have the ability to assure you can maintain the workforce and the modernized types of disease detection systems and laboratories, because one health threat can lead to another health threat, and many health threats can happen at the same time. We saw that, for example, during the COVID-19 pandemic. Health departments that were not only addressing COVID-19, were also addressing Mpox. I mean, these don't happen in isolation, and it's critically important that we have the resources to be able to address the multitude of health threats that exist in communities.
Thank you. The next question is about the administration's calls to cut the federal budget, cut the federal workforce. Congress is considering reducing the federal budget. What are these potential reductions, both in spending and workforce? How are they going to impact public health and readiness? Any member of the panel? Dora, do you want to begin?
Sure, and then I can turn it over to Dr. Shah. We're already seeing some pretty significant impacts. One is the loss of expertise at CDC, and in turn, that expertise that they are providing to the field. When you lose that workforce, it's very difficult to rebuild. So we have the world's experts in a lot of different conditions at CDC and working with state and local health departments on their responses. We're also seeing, as we've said before, 80% of CDC's domestic budget goes out the door. So when we have significant cuts, it's very difficult to retain that capacity at the state and local level. And it means that emergencies will become even more of a federal responsibility and more expensive. As Dr. Shah said, a measles vaccine is relatively cheap, but a measles response is very expensive in terms of monetary and in suffering. So we're going to have major impacts and be less prepared for future emergencies.
Dr. Shah?
You know, I've been thinking about this question for quite a bit. All of us in public service who've been involved in government or in the public sector, all of us agree that where we have inefficiencies, where there's concern for waste, we want to have effective and efficient government. Absolutely. But we can't just cut for the purpose of cutting. We have to be really mindful of the impact on people. It has to be a reminder that all these different agencies that are at the federal level, that we sometimes think of them as disconnected from community, from the very people that are on the ground that are getting those services or benefiting from those activities. And they're not disconnected. They're absolutely connected. So I would say if it's inefficient, if it's not effective, if it's wasting dollars, absolutely bring it on and let's have that conversation. But let's not just for the purpose of making broad cuts say all of it is a waste when we don't know that. And that is the biggest concern I have, is that especially when you're dealing with emergencies, you may not see it today, you may not see it tomorrow. You know, Americans, we may think for the next week or 2 months and 6 months from now, everything is okay. And we don't even miss the dollars that have been cut or the infrastructure, the programs, or the people that have been cut. But one day, something happens. And we now go back and we repeat the exact same thing we've been doing for decades, which is rinse and repeat. We blow the infrastructure, we remove the people, and all of a sudden something happens. And now we're playing catch up and we're spending more resources to make ourselves respond to that emergency. That's not a smart way to do it. So we have to be thoughtful and we have to really be all about, yes, let's think about efficiencies and effectiveness, but let's be thoughtful on how we go about doing our work.
We also, if I may add, want to not turn back on the progress that we have been recently making, in particular too, as it relates to disease detection. There have been some really important investments in terms of funding through emergency funding because of the recognition that we needed to shore up and strengthen our public health infrastructure. And that includes our laboratory systems, our disease detection systems, the workforce, and other disease detection capacity. You know, if you look back just a few years ago, we didn't have a national wastewater surveillance system to be able to do this type of disease detection, to more rapidly identify, detect, and contain infectious disease outbreaks. We have now a Center for Forecasting, for example, to be able to have more predictive capabilities in terms of the track and trajectory of outbreaks, just as we would utilize, for example, as it relates to weather-related emergencies. The modernization of data systems, the number of stories that can be told of health departments that, because of the chronic underinvestment in state and local health departments, where especially small local health departments that had to rely on fax machines to be able to transmit data during times of a crisis, which slows down the response, increases the likelihood of more people suffering in whether it's an infectious disease response or a weather emergency and the like, to actually investing in that data modernization so that we can have, for example, now electronic systems. We've seen an exponential increase, for example, between in electronic case reporting, where hospitals are transmitting information to health departments at a much more rapid pace. The ability to then be able to transmit that data and identify where these types of diseases, outbreaks, disasters are happening has been critically important to improving our disease detection capability and doing what is helping to reduce impact in terms of hospitalizations, deaths, and the economic costs that we see with these emergencies and disasters. These investments are so critical, and we know that they were beginning to pay off in dividends with regards to how we address emergency response. But as you have heard, with this kind of boom and bust cycle of funding, where we fund when the emergency happens, and then when the emergency ends, that funding ends or it's redirected to other purposes, we then lose the progress that we've gained, and we revert back to this kind of austere state for public health to be able to address a multitude of crises, as well as promote health on a day-to-day basis in a non-emergency times, to be able to address chronic diseases, maternal health, child health, injury prevention. We should be increasing and sustaining funding in public health, because that is vital to our health security, that is vital to our economic security, and that's vital to our overall national security.
Thank you, Dr. Gracia. We're about to wrap up. Any final comments from anyone?
I'll just close. Oh, please go ahead,
Yeah,
Dr. Shah.
I was just going to say that I think it's important for us to remember that we must protect the health and well-being of all Americans. And in order to do that, it requires investments. These are not just expenditures, these are investments. And just as when we're thinking about going off to school or doing something for our kids for the future, or we want to plan for something, you have to invest. And these are sacred trusts, and we in public sector must make sure that we're effective and efficient by those dollars. But we also have to have those dollars in order for those investments to be there, again, in advance of the emergency, during the response, as well as whatever the future brings when you're building back the resilience of the community post-emergency. Those are important factors, but they don't start unless you have the investments and you continue to remind everybody of those investments. And what I really appreciate about this report is that it's not just about talking about it, it's also about showing indicators and really giving some objectifiable measures that allow different systems and different partners and entities to be able to see where there has been success, how we can learn from that success, and where we can model it for those who have some additional work to do. Thank you for allowing me to have the opportunity to join you today.
Dr. Gracia, did you want to make a comment?
Just to close and reiterate appreciation for your interest in the report, and to underscore Dr. Shah's points that when we speak about these cuts in terms of the federal budget to agencies and to the workforce, that those cuts don't just rest in Washington, D.C., that those will be detrimental to states and communities across the country. So it is vital that we continue to uphold and invest in the federal public health budget and workforce so that we have the resources that all states and communities need to be able to protect and promote the health of residents.
Thank you, Dr. Gracia, and thank you to all our panelists. We're going to close in a minute. If you have additional questions to reporters now, if you have additional questions or would like to speak to one of our panelists this afternoon, please send an email to the same email you used to RSVP for today's session. It's TFAH@burness.com. And we'll get back to you this afternoon to answer questions or set up interviews, whatever you need. And another reminder that these materials that we've shared and today's discussion are under embargo until 12:01 a.m. tomorrow. So overnight tonight, 12:01 a.m. on Thursday. Thanks for your interest. Let us know if you need anything more.